little bit. But I do want to ask you a little bit about narcolepsy type 2 and idiopathic hypersomnia.
Yes.
It's really been evolved, I think, over the last 5 years as far as our understanding of what those conditions are. And, you know, what can you tell us about how we're kind of like coming to some better understandings?
So I think we are in a very, I'm going to say maybe I'm not politically correct here. I don't know, but we're a little bit at the, no, it's okay, at the destructive phase. Okay. What I mean is that we have had a lot of assumptions, made a lot of assumptions about what these problems are, whereas we knew absolutely nothing. You know, like idiopathic hypersomnia is different from narcolepsy without cataplexy. It's very clear from more and more studies that there's no real limit. You know, it's like, I'm sorry for the noise, but it's almost like the flip of a coin. You do an MSLT, which is a test we use. Sometimes there's SORM, sometimes there's no SORM. If you don't have narcolepsy type 1, it can be just random. And it's pretty awful because some people are treated because they are called narcolepsy type 2, and others, it's much harder with the insurance, whereas they have exactly the same problems. They suffer as much. So everyone realized that there is a problem and that we need to come back and figure out a way to better study this condition and better realize where the subgroups are. That doing this MSLT to separate the subgroup is probably not the right way to do it. But the problem is, like for in a lot of cases, when you come back, it's also a little hard. I mean, you just have to two-step back to better jump, as we say, and that's exactly where we are. But I think we have a lot more hope. And one of the big hope I have is thanks to new technology. I mean, I haven't discussed that much in this talk, but I have a little piece of myself that does a lot of machine learning and high, computer science as applied to narcolepsy. And for example, now we can diagnose narcolepsy based on a night sleep study without doing the MSLT. Just by the brain waves during the night, we don't really need the MSLT. Even so, it's not yet in clinical practice. We feel very strongly it works as well. So in theory, you could just do only a sleep study like for sleep apnea and know if you have narcolepsy. So that's already a big progress. But we also know that just doing a sleep study is not the best way. The best way would be to give you something that you can wear for 3 days, continuously move around, do whatever you want, go to bed, like a little cap, and then we will see exactly how is your sleep and your wake in a natural environment. Then we will really know your problem. I'm a big believer in how people live is really the key, is that right? And I think we need to apply this kind of new technology to narcolepsy and hypersomnia. And for narcolepsy type 1, it won't change that much because we have very good diagnostic procedure, even the MSLT works well. But I think for hypersomnia, we'll probably realize that there's very different types of waves in different people. And I'm sure that they will have different treatment. And I think we'll make a lot of progress. So my opinion for hypersomnia and narcolepsy without cataplexy is we're a little bit in a destructive phase, but at the same time, with the new technology that's coming, we have the opportunity of looking at it in a new way that I think is going to make a lot more difference in how we treat it. And also the other positive, of course, is that we have all these new treatments coming in. I mean, now there is a lot of interest in helping people who are tired and sleepy. And, of course, there is drug to replace orexin, hypocretin. There's histamine drugs. I mean, there's a lot of interest in helping people with this kind of problem, staying awake. But I think right now, it's like we take a dart and then we throw it at the patient and we just hope it's going to work. And that's pretty much what I say to my patient. If they have narcolepsy type 1, it's pre-codified. But for narcolepsy type 2 or idiopathic hypersomnia, it's trial and error. Of course, there's a little bit of intuition. I mean, every doctor will tell you, yes, I know very well what to do, but the truth is it's a little bit of intuition, but it's not worth much. It's really trying and error.
Right. I think that's true for everyone. I mean, because all of our bodies are different, so.
That's true, but for narcolepsy type 1, for example, there's still like the same biology exactly, so the expectation of a response is much more clear, and we see it, pretty consistently. And of course, when we will have orexin agonist or hypocretin agonist, I mean, of course, that will going to be even more clear, in my opinion.
Yeah. So I just am so glad that there's more research and interest in this area, because I, for a long time, felt like most of the research, or all of it, was in narcolepsy type 1, which of course is what I have, and so it's important. But I know a lot of people have type 2 narcolepsy and idiopathic hypersomnia. So
Yes.
it's a very, like, I don't know if I'd call it destructive, but there is a phase of movement right now as far as our understanding.
Yes,
and our
destructive is true. It's not, no. Yeah, I don't know if destructive is the right term, but I think we are really looking at it again in a more objective way. And it is really good. I mean, I think it's going to, I suspect we will define new types of disease that will be much better the target of specific medication. We just need to do more study. And by the way, of course, I've always been interested also in idiopathic hypersomnia and narcolepsy type 2. But the reason I have not studied that is, first, that narcolepsy type 1 seems to be much better defined. So I knew it has more chance of finding a result. I didn't have to do this when I'm trying to redefine the problem, you know. It was already very well defined. And also now it's mostly solved. So I think definitely a lot more people, including myself, are going to work on these other conditions.
Good. I like that.